I'd like to hand over to Mike. I've sent him a number of questions, but he's got a presentation, so I'm going to hand the floor over to him. A couple of questions have been sent in to Mike, so he will address those along the way. If you've got particular questions, the gang in Moresby is keeping an eye on the chat. Please ask questions and I shall call them back out to Mike. So Mike, I'm handing over the host to you. And with that, welcome to Businesses for Health. Thank you very much for your time, your expertise, and your sharing of the great knowledge with those interested who have followed us for so long during this global pandemic. Thank you, Mike. You're the host.
Okay.
Got it.
So can you all see that?
Yep.
I'm sorry I got Business for Health instead of Businesses for Health. I hadn't realized.
That's all right. We are not a business. We are working for all businesses.
So I'm responding to this question from Tracy Ewan from the Child Fund. In many high-income countries like Australia, the COVID pandemic looks like, the images are blocking. Okay. Like we'll come to an end this year if we don't have any new variants of concern, with high vaccination rates and ability to roll out boosters quickly, ability to afford new treatments, and decreasing severity of the Omicron variant. What do you think will happen to places like PNG, where vaccination rates are likely to stay low and health systems are already breaking down after 2 years of COVID strain? Will rich countries move on in a safe bubble and just leave PNG behind? Now, I'm going to take a roundabout way of addressing that question. And despite what Anne said about statistics, being an epidemiologist, I can't resist showing graphs. So I just wanted to point out that this recent wave, mainly due to Omicron, has been by far the largest wave of any variant of COVID since the pandemic began. Now, this graph, which is from the European CDC, shows the dark blue bars are cases in Europe, yellow in Asia, and pale blue in the Americas. Now,
Mike, I'm not seeing that. You're still on slide 1 for me.
Oh, this has happened to me before.
There we go. You're good.
You've got it?
Yep.
Got it? Yes?
Yes.
Okay. So I'll start again. Dark blue bars, Europe. Yellow bars, Asia. Pale blue bars, the Americas. And the green up the top is Africa, which you can hardly see. And the green down the bottom is Oceania, our region. Can you see that?
Hardly see it at all.
Maybe it's a bit slow going through. Now, deaths.
Perfect.
Okay, so deaths have also increased, but you'll see they haven't increased to the level of previous waves. And that's largely because certainly Omicron is less severe than Delta. And if you go back to the middle of last year, you'll see a big spike in yellow, so deaths in Asia. And that was largely due to Delta in India. So this time we haven't seen as many deaths in Asia, but still it's a significant increase. Can you see that?
Yeah.
So what's happening? As of this week, cases are declining now in most European countries after huge spikes, except in Russia and in most Scandinavian countries. In Scandinavia, they've dropped most restrictions. Denmark, all restrictions, and cases are still increasing. Cases have also declined in the Americas. Omicron arrived later in Asia, first in South Asia, especially India, but cases are now declining. So Omicron has now arrived in East and Southeast Asia and the Pacific. And this is really the epicenter of new cases in the world. And it's affecting high, middle, and low-income countries. It's not differentiating between them. And Omicron has spread rapidly, even in countries with high double vaccinated populations. Now, more graphs. Can you see that? Yes?
Not yet. It's still showing. There you go. Yes.
Okay, South Korea, incredible. You can hardly see the previous waves of cases in South Korea. So they're reporting about 120,000 cases a day, even though it's a country that up until now has managed the pandemic quite well. Can you see that?
Yeah.
Another high-income country, Japan. Cases, fortunately, are coming down. But again, you'll see just how many more cases have been reported in Japan compared with previous waves. See the next one, Vietnam.
We're still on Korea, Mike.
Oh, on Korea. I think I have to go out of screen.
There we are. We're in Vietnam now.
Vietnam. So a big spike in Vietnam. As you know, Vietnam had almost no cases up until the middle of last year. Then they had spikes of Delta, and now they've got a huge spike of Omicron. Cambodia. You can see.
Yeah.
So Cambodia is one of the most highly vaccinated countries in Asia. There's a very high vaccination rate. And you'll see last year they had a big Delta outbreak. They accelerated the vaccination program. Cases went down, but now they're spiking again in Cambodia. So you can see high-income countries, low-income countries. Now we have some middle-income countries. You see Malaysia?
Yes.
Singapore? There's absolutely no sign of cases declining in Singapore. And now we come closer to home, Indonesia. You see that?
We're still on Malaysia.
Now?
Yep, Indonesia.
So Indonesia's reporting a lot more cases than during last year's disastrous Delta wave. But fortunately, the number of deaths in Indonesia has not increased. I mean, it has increased, but nowhere near the number of deaths that were reported during that disastrous period in the middle of last year. From what I understand, Indonesia has been a lot better prepared for this outbreak than it was for Delta. The health system is functioning far more efficiently. Contact tracing is working. People are being notified within 24 hours of testing positive. And of course, Indonesia purchased a large number of these new antiviral drugs, and they are being provided free. So you get a text, you have a telehealth consultation, and then they drop off or mail the antivirals. Coming into the Pacific, can you see that?
I can see Australia.
Yes, so Australia's had a massive spike. In fact, if you look prior to January 2022, you can hardly see any cases. And Australia's had 3,000 deaths since January the 1st. And that compares with 2,000 deaths up until the end of last year. Now, cases are declining, but they've kind of plateaued at the moment. I haven't seen the South Australian cases today, but South Australia is kind of steady at the moment, as is New South Wales, Queensland, other states. The exception is Victoria, where cases continue to decline. New Zealand looks a bit like Vietnam. Can you see that?
Yep.
You can see they're experiencing way more cases than they ever have previously. Again, like many other countries, the number of deaths has not increased. They've had much fewer deaths than Australia. And I think that's because in Australia, people in aged care residences were not protected adequately. Solomon Islands, close to home. Big spike after almost no cases up until this year. But fortunately, cases are coming down in the Solomon Islands, as they are in Kiribati, but they're still increasing in French Polynesia, Palau, and New Caledonia. Finally, we have the rather unique graph in Papua New Guinea, in that daily cases just go up and down, up and down, and up and down. And I think that's due to the kind of erratic testing regime and also reporting. So there are a lot of delays between cases being detected, say, at a provincial hospital and being reported to the Ministry of Health in Port Moresby. Can you see this now?
Okay, we've got text, global implications.
So I think what we've learned in the last 2 months is the demonstrated need for a third vaccine dose to prevent infection, although 2 doses still protects against severe infection and death. But we have seen in Australia deaths in elderly people who had just 2 doses more than 6 months ago. And so their immunity had declined over time. Now, widespread transmission across the world raises the potential for new variants to emerge. Now, this virus doesn't have a brain, but it does have a strong survival instinct, and it mutates all the time. But most of those mutations go nowhere. They don't lead to any advantage to the virus. But we have had 5 what we call variants of concern so far. And now we have what's called a subvariant of Omicron called BA2. It's quite new, and it's reached at least 18 countries, including Australia. It evades the immunity conferred by vaccines or previous infections more so than its Omicron predecessor, BA1, and it's also more infectious. Now, we don't yet know whether it's more severe, but there are some troubling indications. So in 3 countries, Denmark, South Africa, and Israel, which have quite a lot of this new subvariant, BA2, are seeing a surge in COVID-19 deaths. And this is after the number of cases has gone down. So people are a little bit concerned about this new subvariant. Now, the 5 variants of concern recognized by the World Health Organization have emerged either pre-vaccination, so it was Alpha in the UK, Beta in South Africa, and Gamma in Brazil, or in countries with low vaccination rates, Delta in India, Omicron in Southern Africa. There's also the fear that in the population, immunocompromised people, for example, people with untreated AIDS, may be infected with the virus for many, many months. And that may lead to mutations that are then spread to the population. Now, we know that was the fact with a chronic AIDS patient in Boston, which led to a new variant. And we think it probably occurred in Botswana that led to the Omicron variant. So low vaccination rates pose a very high risk of evolving mutations. But I might add that because these mutations are so random, they could occur in Australia or Denmark or Sweden or the US, but it's more likely they'll emerge when there are low vaccination rates and people have the virus for quite a long time. Can you see that? New graph?
Yes.
Now, Denmark has a high vaccination rate. It has a very high rate of this new subvariant, the BA2 variant. It has dropped all restrictions.
Wow.
And you can see the deaths are still increasing in Denmark. Now, 35 deaths a day in a country with a population of 6 million is the equivalent of about 150 deaths a day in Australia. Currently, we're reporting about 40 to 60. So the situation in Denmark is very concerning. And I think it does not offer a model for easing restrictions. Now we come to vaccine equity. Everyone see that? The map?
Not yet. There you go.
So the darker the greens, the higher the share of the population receiving at least one dose. And the pink and the red are down below 35% and 20%. And so you can see in sub-Saharan Africa, almost no country has, except Morocco, has a vaccination rate that's just one dose of greater than 50%. And of course, if you look to the right, you'll see that Papua New Guinea is the only country in the Western Pacific region that has a vaccination rate less than 20%. So vaccination rates continue to lag in low-income countries where only 12% of the population has received at least one dose, compared with 79% in high and upper middle income countries that have received at least one dose. And even one dose is not very protective. In fact, it's not protective against Omicron at all. You can see the next slide.
Yep.
So what are the implications for Papua New Guinea? As of today, the 7-day average daily cases are 222. So a lot lower than the peak of around 400 during last year's Delta wave. Highest number of recent cases in NCD, Eastern Highlands and Hilo. Now, there's not very much genomic surveillance in PNG, and only 14 cases of Omicron have been identified, compared with more than 700 cases of Delta. As you all know, the testing rate in PNG is very, very low. Now, if you look at all the tests that have been done since the pandemic began, it's 27 tests per 1,000 population. So that compares with 546 per 1,000 in Fiji, 182 per 1,000 in Timor-Leste, and 296 per 1,000 in Indonesia. I won't show you the figure for Australia. It's many times higher. Now, the national positivity rate's 13%. That's with PCR. The World Health Organization suggests that if the positivity rate is greater than 5%, then positive cases are being missed. So you need to get the testing rate up so the positivity rate goes down. As also you all know, vaccine hesitancy is high in PNG. There have been a number of surveys, but one last year by the World Bank found that only 18% of people intended to be vaccinated. And the main reason was concerns about vaccine safety. You see this next slide?
The road ahead.
The COVAX initiative it had a very slow start, and people were a little bit pessimistic about achieving its 2021 goal, but it has delivered 1 billion doses. And more rich countries are contributing to COVAX, but also sharing vaccines with low and middle income countries. Australia's shared about 20 million doses of vaccine with our neighbours. There's also new vaccines, which are cheaper, easier to store, so they can be stored in the fridge, and can help increase coverage in low-income countries. So late last year, WHO approved a vaccine called Covovax, which is produced in India and is much cheaper than any of the Western-produced vaccines. Now, there's an exciting new vaccine using quite old technology. It's called a subprotein unit vaccine. It was developed in Texas. It's called Corbavax. And what's interesting is the people who developed it are not seeking to patent it. And they've already issued licenses to a number of low-income countries. India is the first country to approve this vaccine, but I think in the near future, this exciting new vaccine, which also can be stored in a fridge, will become more widely available. WHO has also established 2 technical hubs, one in Cape Town and one near Seoul in South Korea, to share mRNA vaccine technology with selected low and middle income countries, and they include Indonesia, as well as Vietnam. So finally, you see that in PNG? Yes?
Not yet. There you go.
So I think it was in an earlier slide, only about 3% of people in Papua New Guinea have had 2 doses of vaccine. And there's a lot of vaccine hesitancy, a lot of misinformation. And so PNG really must find innovative methods to reduce vaccine hesitancy. And I'm sure you all know that. And I think a lesson from the HIV pandemic is you have to reach out to communities and community organisations, mobilise churches, respected doctors, just like Clement Malau raised a lot of awareness about the dangers of HIV, politicians, of course, and local leaders. And they need to squarely address misinformation, particularly about vaccine safety. We need to expand testing, both PCR and rapid antigen tests throughout the country. And I think this is where private businesses can support this effort. Banks, supermarkets, other businesses out in the provinces. Now, PNG went through a period of mass polio vaccination campaigns a few years ago. And to do that, it was clear you have to engage with local communities. And I think that needs to be a pillar of accelerating the COVID-19 vaccine rollout. Now, there's clearly not enough genomic sequencing being done in PNG. I don't believe the figures on Omicron. I'm sure it's a lot higher. And so maybe PNG could work more closely with Australia, like the laboratory in Brisbane or the regional laboratory in Melbourne, to monitor variants so that the country's aware of what it's getting into. And let's not forget that vaccines are not the only strategy we have. Before vaccines, we employed various measures. And one of the most effective is indoor mask mandates, particularly in areas where there's transmission. I mean in supermarkets, I mean in cafes, in shops, everywhere indoors where we know the virus is transmitted through the air in very small droplets. And so we shouldn't forget these measures. I think businesses need to address ventilation more comprehensively so that their businesses are safe. And there is some quite basic technology like what are called HEP filters that filter the air and rid it of the virus. We know PNG has a very hot climate. It's often very hard to keep windows and doors open. So, look at what measures businesses might employ to make their workplaces and retail outlets safe. Thank you.
Thank you, Mike. Ventilation is, of course, our lifeblood in talking about reducing the impact of tuberculosis. Mike, I had made a little note to ask you about the Corbevax vaccine. And when Stephanie did her presentation in November, the technology that she was discussing was about only about the J&J and the AstraZeneca vaccine. Could you give us a brief, how will this new license-free innovation work as a vaccine?
Well, as I said, it's not new technology. It actually injects particles from or segments of the spike protein, which is the protein that allows the virus to enter our bodies. And then that induces an immune response. This is very similar to the technology used for hepatitis B vaccine. It's not that different from Novavax, which also is a protein-based vaccine. And both of those don't need to be frozen. So they have the advantages of the mRNA vaccine. And so far, now the trial data have not yet been peer-reviewed, but it appears that this new vaccine, Corbevax, is 100% effective against admissions to ICU. And it's 75% effective against any kind of symptomatic infection. Now, the trial was done during the time of both Delta and Omicron. Now, they haven't disaggregated the data to see whether there was any difference between its protection against Delta and against Omicron. But it looks like a good vaccine. Now, India does not approve vaccines unless there's good data. So I'm quite encouraged by the fact that India has authorized the vaccine, and the company has put in a request to the World Health Organization to seek emergency authorization. So I think it's something to look forward to. I think they've signed agreements with companies in 6 or 7 low and middle income countries to produce this vaccine.
Fantastic. Because I know we've got a little bit of time to take more questions, may I was doing some reading the other day, and there were a number of best and worst case scenarios from where we are headed in terms of the global pandemic. And being a devout pessimist, I went to the worst case scenario. In the worst case scenario, they talked about the coronavirus being transmitted back into the animal reservoir and then coming out as being something worse. would you like to talk about that? How could that be, and can you explain that whole thing that happens in terms of where did this come from, but how could that possibly happen with the coronavirus?
Sure, there's been a lot of speculation and some research on this, but so far it hasn't been proven that the virus has gone into an animal reservoir and mutated and then being retransmitted to humans. Now, at the beginning of the Omicron wave, there was a lot of speculation that that had happened in Southern Africa and that the virus had somehow got into a reservoir of animals. That has not been proven because no animal has been identified that is carrying the virus. The other, of course, area of interest is in North America, where high prevalence of the virus has been found in white-tailed deer. Again, there's been no proven case of a deer infecting a human. And you may have seen the Atlantic article about the possibility that the virus had spread into mice in New York City and perhaps come back. Again, that's still under investigation. Certainly they have found mice with the virus, but they haven't yet been able to prove whether mice have infected humans. And no one's really come up with a plausible theory about how, in fact, mice would infect humans. You know, we may be terrified of them, but they don't bite us very often. Sorry.
That's right. Mike, I can see a person called David Slattery.
Oh, just another one.
Oh, go on.
Mink. Obviously, we know that people infected mink in the Northern European countries. And again, still not proven that the mink infected humans. Likewise, the hamsters in Hong Kong, yes, they are infected, but no person who attended that pet store has been proven to have been infected by a pet hamster.
Okay, so we need to, I'm going to reclaim the host so that I can open the mic to our friend David Slattery. Dave, if you're free to open and ask a question.
Thanks, Anne, and thanks, Mike, for the presentation. Yeah, look, I work for the Foreign Affairs Department here in Canberra, looking after PNG matters, including sort of responsibilities for health. I guess my assessment is based on current vaccine uptakes that there's hard yards ahead for the vaccine rollout, and at the same time got some major concerns about the health system more broadly. Routine immunisation rates, for example, are sort of at the bottom of the world tables. So I guess one of the things I'm sort of trying to think through is what are the prospects for using or channeling the resources that are dedicated to COVID vaccines to sort of strengthen PNG's health system more broadly, and what are the prospects for sort of integrating an approach to COVID vaccination rollout with, for example, routine immunisation? Thanks.
Yeah, it's a good question. The partnerships program that's funded by DFAT does, in fact, allocate a couple of $100 million to improving health systems, to supporting logistics in the region to deliver COVID. Now, if you look at the data on the website of the Centre for Health Security, or the Indo-Pacific Centre for Health Security, something like 5 million doses have been given to Vietnam, but the number given to PNG has stalled. And as far as I understand, that's because the uptake is so slow, that really there is no supply issue in PNG. COVAX is providing vaccines, and they would provide more if asked. Australia would provide more if there was a stronger uptake. So I think I don't have the solution, It's a very difficult one. Perhaps PNG could look at other Pacific countries that have much higher vaccination rates, like Fiji, like Tonga, like Samoa, like Kiribati, Palau. These all have much higher vaccination rates and Solomon Islands than PNG. And it would be interesting to know how they mobilise people. Nauru vaccinated everybody in a day. And they had no problem because it's a very small population. But there was no resistance whatsoever. So I think it's important to identify why is hesitancy so high in PNG? How can those issues be addressed? And I would think it's something around the approach of engaging with communities, as was done with HIV. You remember the Tingam Life program that was funded by DFAT, which was a community-based program to prevent HIV. The measles and polio national vaccination campaigns all required community engagement. I remember reading a paper about measles immunisation, that they just could not get the rate up until they took a strategy, the Minister of Health, took a strategy of engaging with communities and mobilising them. And it's tough, it's hard work, but I think it has to be done, and it's not that expensive. We're not looking at technology here. We're looking at basic communications, theory and practice, behaviour change.
Thank you, Mike, and thank you, David. And I would like to make a comment here in direct contrast to what Mike has said. If we round off the number of vaccinations being given in Papua New Guinea at around about 300,000, the fully dosed population is around about 200,000, and that number curiously links in size to the number of people in the formal private sector workforce. And the formal private sector workforce in PNG is astronomically small by comparison to other countries. And this forum and the power of the business councils and those who drive industry and formal private sector activity in PNG has been fantastically successful. Last year, we had a tiny grant from the World Health Organization to mobilize very poor workplaces in PNG. The people who you see on our screen today all represent much more privileged workplaces in PNG. But none of the vaccine hesitancy or resistance after our program was 2 face-to-face visits by the team with accurate information, locally produced materials, links to well-respected organisations. And the team in Moresby went face-to-face, they visited twice, and they provided a third occasion to have a public Q&A type session, which is your community engagement outside small shops. And we had, at the end of 6 months, we had over 30% of them had been vaccinated, 20% said they were planning on being vaccinated, and a bunch said they hadn't made a decision yet. But the absolute no resistance was very, very low after our small engagement. And the message from that does link exactly to what Mike was saying. Face-to-face community people with trusted organisations. And we went with health extension officers, we went with a male and a female, we gave them information that was from PNG, from the health department, with that was all held in high regard. And it was time expensive, it was human resource expensive, but if you want people to get vaccinated, you've got to talk to them. And in terms of that combating what people are seeing in social media, which is faceless, but it's also not very powerful when you've got people to talk to. That said, we are going to continue with that program this year, but we are going to ensure that to go back to the other thing that Mike said, is that the understanding of airborne bacteria or airborne viruses and infection and prevention and control can be shared. And I think 2 years down the road, the private sector quite literally threw up its hands and did everything they possibly could to address COVID at the expense of everything else. I don't think that the private sector in PNG will do that again for a third year in a row. I have 100% faith in the 75 people who are online with us today who are going to say, oh, we need to address tuberculosis and COVID. We also need to address the rates of vaccination in the children of our employees, and the power of the private sector workforce to influence its communities by employing the people who pay for those families and communities is a really powerful force. So I'm really pleased to know that you're online to us here in PNG. Well, sorry, I'm not in PNG today. I'm in Adelaide, but everyone else is in PNG. So thank you for your question.
I'd like to go back to the Tingum Light program,
yes,
the high-risk setting approach, where the private sector played a very major role. My memory's not so good these days, but there was a sugar refinery in Morabie. There was a fish processing company in Madang. There was Lihir Gold. There were a number of private sector companies that really gave that program a boost. And they didn't smother the dialogue. What they did is basically give some resources to the community committees or teams that ran that program in each of the sites. And so there's certainly a precedent for the private sector in supporting community-based initiatives to control an infectious disease.
100%. I'll remind you, it was Ramu Sugar over in the Markham Valley. And I mean, there was an example of a company who had the Business Coalition Against HIV's logo stamped on its sugar packets, and it participated with Tingum Life. It didn't do one thing, it did many things. And I'm pleased to say that the fishing cannery business has also engaged with us to talk about TB. So some of those businesses are still working to participate in that. And as I said, and the 75 people who have been online from workplaces here today, where people have had the opportunity to ask questions. Eric has asked questions about improving what can workplaces do to coordinate better with the NDOH? And my answer to that, Eric, is please call me. We'd love to have a message from you. So Laurie's going to send you a message and say, how can we help? That's what that is exactly what we're here to do, to help give you ideas, to talk about getting people together, to talk about infectious diseases, infection control, and better management. Policies and programs that help drive engagement and change the culture of health-seeking behaviour. And Stephanie was online at the meeting yesterday, which was really quite funny because there was a bunch of tests that came in, positive Omicron tests, and only one of them was from a PNG local. All the rest of the positive tests were amongst expatriates.
Wow.
So there are two questions that you can ask. Are, in fact, Papua New Guineans immune, or are Australians better at going and getting tested?
I can guarantee that Papua New Guineans are not immune.
Oh, Mike.
There is no identified population in the world that has been immune to the coronavirus.
We shall frame the recording in the text recording of that statement. Thank you, Mike. I had another question in relation to waning immunity. So we've got about 200,000 people in PNG who have been vaccinated, and a large number of those vaccinated were very early and enthusiastic adopters. We now, obviously, as we well know, have a waning immunity as well as a large unvaccinated population. In looking at those huge spikes of Omicron, it would appear that the current wave is going down, but by the next wave, immune response will have waned even further. How do you think that's going to play out in the next wave, and will there be a next wave?
Well, as I said in the presentation, it's very clear that third doses are essential.
Yeah.
The data are clear from all over the world that 6 months, let's say, look at AstraZeneca, 6 months after your 2 doses or your second dose of AstraZeneca, your protection against Omicron is close to 0.
Wow.
Now, that's based on measuring antibodies. Now, there's another form of immune response called T cells and B cells. Now, there is some evidence that even though you're not protected from getting infected, that once you're infected, those T cells wake up and they start producing more antibody, and that protects you against severe disease. So that's why even in just double vaccinated people in countries around the world, we haven't seen a lot of severe cases. There have been some, mainly in the elderly, and there have been some deaths. But a third dose guarantees your protection. With Pfizer, after 6 months, it's about 30% protective against infection, but it's up to 70% protective against severe disease and death.
Yeah.
But to stop transmission, because let's say I had my 2 doses, say I had my 2 doses 6 months ago and I got infected. So I didn't get severe disease, but then I spread it to 5 other people. And some of those were older people, had pre-existing conditions, or hadn't been vaccinated. So we need to stop transmission so that we can get numbers down, so that we can really get on top of protecting our health systems. Now, you have a big task in Papua New Guinea. I'm not going to pretend you don't. 95% of Australians over the age of 12 have been double vaxxed. And it's only 3% in Papua New Guinea. Now, those 3% probably got AstraZeneca from Australia. If they got it more than 6 months ago, they need to get either another booster of AstraZeneca, or much better than that, if they can get it, a dose of Pfizer, if it's available, or Moderna, or even Sinopharm, the Chinese vaccine.
Mike, it's interesting because I was just about to say we don't have any Pfizer or Moderna, but we do have Sinopharm. So I heard you very clearly there, and at POMGen, that Sinopharm is the only place where, Sinopharm is the only place where, POMGen is the only place where Sinopharm is available. So if people have had 2 doses of AstraZeneca or 1 of J&J, the third or second dose, you would recommend in PNG to be Sinopharm?
Yeah, there's a lot of data now showing that mixing vaccines, so having a different vaccine for your third dose, or in the case of Johnson & Johnson for your second dose, gives you a boost in immunity. And one of the best studies is from the United Arab Emirates. Now, Sinopharm is a pretty good vaccine. It hasn't been full. I haven't seen a lot of data on how it prevents Omicron. But given its history against Delta and other variants, I would think if you'd had 2 doses of AstraZeneca and then a dose of Sinopharm, you're certainly going to be better protected than if you'd only had the 2 doses of Sinopharm. I can't put a figure on it, but again, data from Argentina also points to
Mike, I'm just going to cut you off there to our friend Dr. Julia at Oil Search Foundation, now, of course, Santos, has just said that Sinopharm has not been approved as a booster yet in PNG, but I'm sure after today, the question will be asked because I shall ask it.
Sinopharm hasn't been approved in Australia for a booster, nor has it. So
maybe
it's only
we should ask David Slattery about that.
And not even Novavax. In Australia, it's just Pfizer and Moderna for boosters. But maybe there should be a discussion, because I don't think anyone is really proposing that a third dose of AstraZeneca is going to be particularly useful.
Yeah.
Maybe better than nothing, but I would go for, well, if you had an mRNA vaccine, I'd go for that. So I had Pfizer for my third. But I think Sinopharm shouldn't be. Now, Sinovac's a bit different. Sinovac has not been approved by the WHO for people over 60. And Sinovac in trials was not as good as Sinopharm. I trust the trials for Sinopharm because the biggest one was in the United Arab Emirates. Now, that country can afford any vaccine in the world. They're so rich. I don't believe the UAE would have falsified the results for a vaccine that they now produce and use.
That's a really interesting point. I'm mindful of time here.
Yeah, I have to go at 6. I'm sorry.
Well, it's 5 o'clock in Papua New Guinea, so people need to get into cars or get onto the road. So I'm going to let you off the hook unless can't see any more hands up, and I don't have any messages. And the gang in Moresby text me to see if there's any more questions. No, there's just lots of thank yous. No. With that, Mike, I think this has rounded out our thinking, and I am eternally grateful. The seriousness of the pandemic, I believe, has been reinforced here today. We are not, hello.
He likes to join in on Zoom calls.
And I apologise for my husky. I've gone through walker clock today. The seriousness of the ongoing pandemic, I hope, has been reinforced very clearly by Mike today. But what can we do? It becomes all of our workplaces' responsibility to promote vaccines and to fully commit to ventilation, mask wearing, and the other aspects of the Niupela Pasin, all with which are so easily within our control. And we are fully committed to supporting all of those things, and to ask you over the next month to engage with us. Email me, please. Get back in touch, because World TB Day marks the start of us doing 2 things at once. Because we are all women, we can and we shall work towards reducing the burden of TB in Papua New Guinea. We shall work towards increasing vaccinations, not just for COVID-19, but for infants and BCG and other childhood preventable diseases. And we need every one of your workplaces to engage with us to come up with a coherent plan of being kind and developing a culture where people want to get tested and are not fearful about losing their job or revealing that members of their family are sick. And that's the message that I want to leave you with today. I am incredibly grateful for your time and your expertise, Mike. Mike thought he was going to retire, but he's not. And with that, I'm going to close you off, and I'll keep the line open for a minute. If anyone would like to stay online and catch up or chat, you are more than welcome to stay. But thank you, Mike.
Thank you, Anne.
Thank you.
Thank you. Thank you.
Thank you. Thank you. Cornelius or Keith, I can see you with your hand up. I'll let you unmute. Keith, you're jumping all over the thing there. You can unmute. Keith? Keith, are you there? He had his hand up. Cornelius Keith on the screen. Welcome to speak. Hi, Ed. How are you?
Hi, Anne. Yes, I'm well. And you?
I am extremely well, thank you.
When are you coming back?
When someone sends us some money.
We're all paid up, so you should be able to come.
I sent a request for a business visa so that I can come and visit and get things sorted for World TB Day, and we would like to have a function on World TB Day. Actually, would SP like to host a World TB Day drinks?
Yes, why not? Of course.
There's the answer to that. We're sorted. Thursday the 24th at 6 p.m. at the Brew Kettle. That's fantastic. You've just answered.
24th of March?
March the 24th. And we would like to have all of our current sponsors and participants and our industry leaders who need to hear some of the key messages from Mike, but need to hear very clearly the key messages about what's happened to TB in the last 24 months, which has been literally catastrophic.
Right.
So I could, in my wildest dreams, I did not know that tomorrow's disastrous questions of hunting what to do for World TB Day. My wish was for a function on that day to brief, and the sorts of people will be Port Moresby Chamber of Commerce and Australia PNG Business Council and PNG Business Council people, with a short presentation. And I've come up with a list of easy questions to get people to how can you re-engage in this TB and COVID exercise for 2022.
Right.
Yeah, it's.
But it have to be, there's still a measure is still valid. No gatherings over 100 people. I know.
Well, that's easy. We'll make it 99.
That's it, because we can't break the rules.
We cannot break the rules. And if you want, I would be happy to stand in the car park.
It would still constitute a gathering, whether it's inside or not, right?
I'm talking about me. I'm chicken. I don't go anywhere where I have to eat inside.
All right.
And if possible, I meet people outside, and I have no interest in getting any kind of COVID, long, short, serious, or simple.
All right.
I've dodged drug-resistant tuberculosis. I'm not going to die of COVID.
All right. Well, I had it about 4 weeks ago now, and I was under the weather for about 2.5 days, and then now I'm all chipper again. It wasn't that bad, actually. And we see in the company, we were testing every day, and then at about 40% of people tested positive, and now it's back down to 20. I mean, so we see that graph of the doctor that was there. We recognize that in the company.
Yeah.
And we're now considering, relaxing our own measures on these things. But like we don't have Friday drinks at the brew kettle anymore. So let me confirm this to you. We have.
Ed, I'm curious. I didn't have time to ask about this post-infection immunity phase. That I'm really interested to know how long that lasts. And there's some research, and of course we've only had 2 years of this, so we can't know how long it lasts. But I was reading something the other day that suggested that people who were infected with SARS-1 from 2004 still had. Do you remember he talked about T and B memory immune cells? That there was a trigger response to that even for Omicron. for people who had a coronavirus SARS-1 infection more than 15 years ago. So it's really interesting to see how these things are going to play out in a community where you and I both know there has been huge amounts of infection.
Yeah.
Remembering, of course, that the average age is 22. Yeah. But Ed, for you, before you let people think that it's not serious, you are lean and you are young.
No, I'm 60. I'm in the red group.
No. Yeah. Not compared to people in Adelaide. There's no one here under 60.
You know, it's the secret recipe is SP Lager.
That's an ad.
All right.
Thank you for joining us today.
Yeah. Okay. Bye, Anne.
Thank you. Bye. Is there anyone who'd like to ask a question who's still online? Okay.
But it was very good, Anne. Thank you.
Thanks, Annette. I'll talk to you tomorrow.
Okay. Do that.
Bye.
Yep. Nice to see you. Yeah.
You
good
too.
work. I wish I'd known about these before, actually. I would have.
Annette, they have been fantastic.
Have
I can't tell you how brilliant some of them have been.
Oh, that's awesome.
We had a competition. We had David Toa, Linda Sirigoy, Shay Scovell, and Melissa Gorogo from Kenmore, and we had a competition for best pitch to your employees on how to get vaccinated. And on Zoom.
Awesome.
It was great.
That stuff.
And it was I couldn't believe that you could actually get a buzz out of going to work on Zoom, but that was awesome.
Yeah.
We had the guy who runs the facility services and air conditioning company, and he did his presentation from the hotel room, and the air vents and stuff were in the background.
And the what were?
The air vents were in the background.
Oh, really?
So he could describe how air conditioning worked. We had I can't think of a bad one. And Stephanie, the girl who was at WHO, she's now working for Burnet for the TB research component of the Burnet TB response in PNG. She did a little presentation on how the vaccines are made and how they get tested, and just that that intense.
Yeah, nice.
She was so clear.
Yeah.
And her manner of speaking was really nice. We had this fantastic young woman from the WHO from their social media misinformation and fake news stuff, and a session on countering misinformation and fake news. She was just delightful. We've had it all. I mean, actually, the thing that brought me to tears, quite literally, was Dr. Maria Maguna, who broadcast. She's the anesthesiologist who puts you on an ICU, on a ventilator in ICU. At the peak of the Delta, she gave a presentation from PomGen.
Oh.
And
did she go live?
She wasn't in the ward, she was in her office.
Okay.
And I still feel it. She said she hadn't put anyone on a ventilator and had them live. And she actually said, why anybody would refuse a vaccine, refuse something that saves your life, why would you say no? I mean, she was so clear.
Yes.
And the way she spoke, the way she talked about how she manages patients and things, it's been absolutely delightful.